and I'll hand it over to Shisha.
Sorry, Robbie, I can't see any screen on mine.
Oh, no.
I just still see you guys in the camera.
Open share tray. Desktop share. Yes. Didn't go through this. Can you see a presentation now?
Yes, I can.
Cool. Okay. And I'll leave that to you.
Yeah, thank you. All right, today we are going to talk about artifacts. An artifact is defined as something that appears in an image which is not there actually in a real object. So today we'll be talking about CT artifacts and MR artifacts. So let's start with the CT artifacts. The CT artifacts can be divided into three different groups. The first one is physics-based artifact. The second is artifact due to patient properties. And the third one is scanner-based artifact. There are three important physics-based artifacts: beam hardening artifact, partial volume effect artifact, and the photon starvation artifact. So what is beam hardening artifact? In beam hardening artifact, when X-ray photons enters a dense subject, most of the low energy X-ray photon get absorbed, and only the high energy X-ray photon get out through the dense object and reach CT detector. And because the energy of photon is high, paradoxically, CT detector assume that the photons are coming from low density material or low density object, and this band-like structure appear. So this is a CT scan axial section of head, and these two bones are really dense bone, which is called a petrous bone. And you can see a band of beam hardening artifact here. But beam hardening artifact can be very annoying. And these are all beam hardening artifacts here. Okay. They can obscure a pathology, they can obscure lesion. So now how can we reduce this beam hardening artifact? And it was found that beam hardening artifact can be reduced if we decrease low energy X-ray photon before it enters high density object. So how we can decrease a low energy X-ray photon? So we can decrease low energy X-ray photon by placing a thin metal between the X-ray source and the object that we are going to scan. And this is called filtration. And the standard filtration in standard CT, filtration in standard CT is 2.5 millimeter of aluminum. That is what we get. So if we are getting beam hardening artifact in our image, we can ask the radiographer to increase filtration. So what we can say is increase filtration, maybe 3, 4, 5, up to 6 or 7. So that is how we decrease beam hardening artifact. So is that clear? Okay. Now, this partial volume effect, another artifact, is also a physics-based artifact. In CT image, every voxel has its own attenuation value in Hounsfield unit, depending upon the material it contains. For example, if it has water, then its attenuation value or Hounsfield unit will be 0. If it's bone, its attenuation value or Hounsfield unit will be 300 to maybe 1,000, depending upon the density of the bone. Similarly, if the material is fat, it will be in minus, minus 150, minus 50, minus 100. So that's obvious. And based on that attenuation value, we identify material. You identify those tissue, whether it's fat tissue or bone or water. But what happens if the single voxel contains two different tissue with two different attenuation value? Then the computer averaged out. So it will take a average attenuation of those two or three tissue. So because this whole this process is called partial volume, and because of partial volume, the age of the object become less clear. So, for example, this is a voxel. This blue circle is high density material, and these are the voxel in the image. The high density material is not in this voxel, so it's low attenuity. The high density material is in this voxel, so it's highly attenuating. Whereas in this voxel, the high density material is partially here, so it's a gray in between. And the tricky thing is this voxel represent this tissue, this voxel represent this tissue, but this voxel actually doesn't represent this tissue or this tissue. Okay. So in the image, this is image. This right image is with less partial volume effect, and we can see a nerve passing through this two bone clearly. Whereas in this image, same patient in this image, because of partial volume effect, we can't see it. Okay. So now, how to reduce this partial volume effect? Partial volume effect can be reduced by decreasing voxel size. So if we are getting images that have, those images, those that images have a partial volume effect, then we can ask radiographer to decrease voxel size. If they are scanning an 800 micron voxel, we can ask them to decrease and scan on 600 micron size, micrometer size. Okay, that is this. This is how we can reduce the partial volume effect. So, is there any question here?
Is that matrix preset usually the grid pattern, and the radiographers, do they often touch it, or do they?
Generally not. Yeah, usually not, because usually this partial volume effect, even beam hardening, just in the clinics, it doesn't make that much sense. We have to just make a diagnosis. We are not interested in age so much, so it's all preset usually, but it can be done. So because we need image for different reasons. For example, in OSIS, we need segmentation. So maybe we have to optimize our own protocol, depending, and that will give better ease for the segmentation and other purpose. It can be changed, but it's it's a standard practice to use. Yeah.
You use protocols which they use in clinics, whereas we want our own protocol.
Yeah.
That's right.
So it's about partial volume effect. And the third is photon starvation. When minimal amount of X-ray photons reach CT detector, the noise in the image get magnified. How it get magnified? and it becomes grainy. So if you see this sort of image, the grainy image, it's because of photon starvation. Okay? So how we can improve, or how we can correct this photo starvation. So if you remember in previous class, uh, actually when the number of electrons moving from the cathode side of the X-ray tube towards the anode side, if we increase that number of electrons, we'll increase the X-ray photon, number of X-ray photon. So this movement of electron from the cathode side towards the anode side is called tube current, and it's measured in MA. So yeah, general practice in the clinic is maybe 150 to 600 MA, something like that, 300 MA. That is a standard practice. But we can ask to increase the tube current. It can be increased up to 1000 MA. So yeah, that is the window. We can ask them if we are getting images with photon starvation.
Do you have a different protocol for like pediatric cases? Because the imaging where we've seen photon starvation has been generally with children, really.
Yeah. We have different protocols for pediatrics patient, and the reason behind it, and then one of the strong reason behind it is we need less exposure, radiation exposure, and as compared to adult.
Yeah.
So one of the so why we don't want a lot of MA, because it will give a lot of radiation.
Yeah.
So but again there is a trade-off. Okay. And in pediatrics patient, we usually don't take a high MA images because of, again, radiation dose. And it is all set up in the computer. It's pre-set up, So you just have to click a switch, pediatric patient, and every parameters are already there. So radiographer don't have to manipulate KV, MA every time they scan.
Yeah.
So this is all about a physics-based artifact. Now, a patient properties artifact based on patient properties, metal artifact, and motion artifact. And the most important artifact for us, I think, is a metal artifact. And metal artifact looks like something like this.
Does that image have both photon starvation and
Yeah, I'll come.
Sorry.
No, it's okay. It's good. Yeah. Yeah, and the metal artifact is in fact a combination of different artifacts. So when we say it's a maybe garbage term, everything is there. So it consists of beam hardening artifact, partial volume effect, and photon starvation. So if we want to improve metal artifact, then we have to improve beam hardening. We have to improve partial volume effect, and we have to improve the photon starvation. And we know how to improve it now. So how can we improve beam hardening? Increase filtration. The standard is 2.5 millimeter of aluminum. We can ask radiographer to increase it if we are getting this sort of image. Then how we can improve partial volume effect? Reduce voxel size. We can ask if there is any possibility of reducing voxel size. Standard is, 800, 600, sometimes 900. But then we can ask them, is there any possibility of reducing it? And finally, a photon starvation. We can increase tube current, usually 150 to 600 ms. We can ask for up to 1000. So that's how we can just reduce metal artifact. Any question? So now about motion artifact. Motion artifact can be due to voluntary movement. like swallowing, or involuntary movement like breathing and pulsating organs and arteries, vessels. And you can see this is, in fact, this is a cross-sectional image of abdomen, and this organ is a spleen, and this double is, if you can see here, it's because of motion, this pulsating motion of a spleen. So there are some involuntary movement which we can't control. Okay. So voluntary movement, if it's a pediatric patient, if patient is agitating, then we can just sedate patient, make them sleep, and take a image. And if the patient is moving due to pain, then we can reduce the pain. Similarly, we can ask patient to hold breath, and we can take, because CT is quick, within few seconds. So the patient can hold their breath, and we can take a better image. But at the same time, there are some motion artifacts that can't be corrected. And the most important artifact, CT artifact, which is scanner based, is ring artifact. So you might have encountered this sort of artifact in images. It's because of defective detector, because the CT detector has to move around the patient to take image. So if the single detector is defective, then it will appear as a ring in the image. And the only solution here is to fix this defective detector. There are a lot of softwares which can mask the ring, but the real information is always lost when there is a software masking. It looks better, but the information is not there. So the best way to fix this sort of artifact is to fix a defective detector. So this is all about CT artifact. So if you have any questions. Yeah. So now MR artifact. So yeah, depending on their origin, artifacts are typically classified as MR artifacts are typically classified as a patient-related artifact again, signal processing dependent artifact, and finally the hardware or the machine-related artifact. Okay. So important patient-related artifacts are motion artifact, flow artifact, and metal artifact, also called a magnetic susceptibility artifact. And the signal processing dependent artifact are aliasing artifact and truncation artifact. We'll talk about this later on. And finally, hardware related artifacts are again magnetic susceptibility artifact, shading artifact, and crosstalk artifact. So these are the MR artifact. Now we'll talk about most commonly encountered MR artifact in our daily practice. So motion artifact in MRI is also called as a ghosting artifact or smearing artifact. And again, it's caused by voluntary or involuntary motion of the patient or the patient part organ. So it can be random motion as well as periodic motion like respiratory, cardiac, and the vascular movement. So this is an example of ghosting artifact due to movement of patient head. This is how it looks like. So it's a voluntary movement. And this is due to involuntary movement. And if you have noticed in this particular case, in fact, it's our OC's case. This is a frontal part of the patient, so abdominal part. And this is a hind part or the back of the patient. This is the pelvis. And if you notice that the artifact is mainly in the upper part, frontal part. So we can assume it's maybe because of the respiration, or patient is voluntarily moving his or her abdomen. Okay, the and the posterior part of the back of the this hip is relatively stable here. So how can we correct this sort of motion artifact? We can correct by identifying or by using a fast scanning protocol. For example, this is two images. One is done in spin echo and another is fast spin echo. And the quality of image is substantial. You know? This is much clearer and sharp as compared to this one. So we can choose a better protocol. So for another example, we can just ask patient to hold the breath for few seconds and take image at that particular time. And again, that correction will significantly improve the quality of image. So metal artifact, it's also called a magnetic susceptibility artifact because the metal disrupt the local homogeneity of the magnetic field and it appears as a void. So here is a metal here, implant probably, and there is a void. And because of that, there is a big metallic artifact over there. So this magnetic susceptibility artifact due to metal can be improved with better protocol optimization, like lowering the magnetic strength. So it's better to do MR scan on 1.5T MRI if the patient has metal implant there rather than 3T MRI. Similarly, taking a thin section, and also we can increase matrix size. Okay.
Question on that one. So with things such as lower magnetic strength, is it possible to do a lower magnetic strength with like 1.5T on a 3T machine, or do you have to go to a 1.5T?
No, I didn't get you.
So 1.5 Tesla. If you're doing lower magnetic strength, are you able to get, if you've only got a 3 Tesla scanner, can you do a 1.5 scan on that, or
no? There's two different.
So that's fixed. The scanner is fixed.
Yeah, because the magnet is fixed. We are talking about.
super cool.
Yeah. I mean, we are talking about the strength of the magnet.
And other question is there any other, my understanding was stronger magnets give better signal to noise ratio, so we get a better signal with less noise, but this here is indicating that lower strength in this application is good. Is there any other applications where we might want to use a lower strength magnet? Except this, I don't think there is any, because with a higher strength, you're right that signal to noise ratio will be better. But what is happening here is it's just exaggerating the artifact. It's just showing strongly that there is an inhomogeneity because the magnet is so strong, and it's not good for us, at least in this this kind of cases. It's trying to rip the middle out of the patient.
Yeah, but nowadays they have MR compatible this implant.
Yeah.
So we don't have that much problem for the
Not magnetic.
Not magnetic.
Yeah.
Didn't you have a case recently where you had screws that might have been stainless steel that could be mild?
Everyone should titanium.
Trying to tell them.
I also can't say that cobalt chrome makes patients crazy. If they get yeah, one of our patients has got admitted to a mental asylum because they
From
from too much cobalt chrome, apparently.
Is the cobalt like bloodstream or something?
Yeah, that's still alluded to bloodstream. I didn't have any metallosis.
No.
No. Which I've never heard of. That should be.
fully illegal.
It's crazy. Yeah, it really surprised me. They must have high levels. They do have a lot of metal in there. It's all cobalt.
Oh, wow.
Yeah. Yeah.
So now flow-related artifacts. Flow can manifest as a altered intravascular signal, especially in the blood. In high velocity flow, like in arteries, even in big veins, protons do not contribute to the echo, and they are registered as a signal void or the flow-related signal loss. And in this image, there are two arteries. It's the basilar artery, and this one is left internal carotid artery. And this T2 weighted image, and you can see there is there is a signal void, and that's how we identify this artery. So in this case, artifact is good for us because now, yeah. So if you have heard that in MR, we can create MR angiography without using contrast. So it's how we create angiography without using contrast. For example, if we have a patient with a contraindication to the contrast, then we can go for MR image without using any contrast and have an angiography. So this is flow-related artifact. Another artifact is a lysing artifact. So if the field of view of MR is less than anatomical structure we are trying to scan, then what happens is that the part of the anatomical structure will go exactly opposite direction. For example, this is a foot, and our field of view is small as compared to the whole length of the foot, and the finger is in this part. It should be there. Yes. So it's also called a wrap around artifact, a lysing artifact. So similarly, this part of the brain should be here, but it went there. I don't think we'll get this sort of the image because it can be corrected immediately. Just you have to increase the field of view, but it's something interesting just to know that this sort of thing happens. So it can be corrected with enlarging the field of view. Another is a truncation artifact. Usually, if it's in the interface of two high contrast interfaces. You know, if there, for example, here is a bone and here is a brain parenchyma, and you can see a parallel line along this border. These are called truncation artifact. And it can be corrected by increasing the matrix size if that sort of artifact appears. So this truncation artifact is correctable. We can correct it. And
so by increasing the matrix size, you're making the matrix finer, or you've got
bigger,
larger.
Yeah.
Larger box.
Yeah. So yeah. And another is the zipper line artifact. So it's a line of alternating pixel, bright and dark, mainly due to radio frequency leakage in MR room. So we know that in last, I think, class we learned about that we use radio frequency in MR imaging, and the MR room should be properly shielded with the properly shielded not to enter stray radio frequency inside it, whether it's a mobile frequency or radio FM. It should be properly shielded. If that's shielded, there is a leakage of radio frequency, then this sort of artifact produced. This is zipper line artifact. And yeah, and it can be avoided using a proper seal in MR room. So usually copper, aluminum, and alloy are used to seal it properly. Or sometimes what happens is a radiographer keep opening the door, and again the radio frequency will come because of the mistake in that scanning room. Okay, so that can be corrected as well.
Does it come through the window?
Huh?
That window that's there? Is that also?
Yeah, it's also properly sealed. So that is console. From there, this is where the MR will be here, and the patient will be here, and the radiographer in this side. They can give a direction or can see what is happening inside it there. But this room should be properly sealed with copper and aluminum and other metallic alloy, not to allow radio frequency inside the room. To summarize, first, the metal artifact of CT images are the combination of different artifacts. Beam hardening, partial volume effect, and photon starvation artifacts. And metal artifacts can only corrected by correcting each of these individual artifacts, and we know how to correct them. Ring artifact is always due to defective CT detector, and it can be corrected by fixing a detector only. We can mask it, but in that case, we might lose important information in the images. And motion artifact is less common in modern CT, because it will for modern CT it will take few seconds, less than a minute to scan, as compared to MR, because the scanning time is long in MR. And in MR, motion artifact is called ghosting artifact as well, and it can be minimized with better imaging protocol. And zipper line artifact is due to stray radio frequency in MR room. It should be corrected, and it can be corrected. Okay. Thank you.
I actually don't have a question this time.
Can you correct for the, I forget what it's called, the voxel averaging by taking a second scan slightly offset?
Yeah, yeah. I mean, I got it. Got your point. But the problem with this partial volume effect, you can't scan multiple times because it's a radiation. Theoretically, yes, we can do it, but then you have to expose patient multiple times, and that's not a good option.
With the CT scanning and the metal artifact, how much can that metal artifact distort our image from the actual surface? Is there an average? Is there a range that we can expect?
I mean, actually, the metal artifact actually obscure the nearby structure. So if there is a metal here, because of beam hardening, because of partial volume effect, we can't clearly see the lesion that is nearby that particular metal.
Mm-hmm.
So that is the problem.
Yeah.
Identifying that particular structure that is nearby this metal, that is the problem. Or identifying its border properly. So how much it will affect quantitatively, I don't know. I mean, but it depends. Maybe subjectively you can say, looking at the image, if the artifact is, there is a significant artifact, it can completely obscure. If there is a little bit of artifact, then it can partially obscure. So Did I answer your question?
Yeah.
Mm.
I guess I've got a question sort of for Nat. Nat, are you there?
Yeah,
just-
yeah.
Yeah, sweet. How much opportunity do you think there is for communication with radiologists and adaptations to our protocol to be used rather than just clinically the in-house protocols being used? I haven't got much of a guide of this, but it's sort of relevant. It's relevant to this topic and presentation, I guess.
Yeah, I guess it just depends around the imaging center as well as the scans. It seems like more recently we've been getting a lot of scans in which the patient had already been imaged, especially these ones where the surgeon's tossing up between using off the shelf and us. But if we did want any feedback from radiology centers, I know there's one in that the surgeons in Sydney use quite regularly. Not sure if there's, the surgeons in Perth, if they use one quite regularly as well, if we want any feedback. But otherwise, generally what happens is that the reps for ZB get sent the protocol and then they should be sharing that with the imaging center is technically what should be happening.
Yep. Cool. I think we might have a bit more of a chat on I'll chat with Vicky and yourself maybe a bit more on getting uptake of any changes to our protocol.
Mm-hmm. Yeah.
Thanks. Any question?
So, Shisha, I gather with a CT, when you increase the power, you're increasing the exposure for the patient. That's why they set it at 150 to 600.
Yeah.
So we've got to have some pretty good reason to want to crank up the amount of energy we're pumping into the tube.
Yeah, and this interesting thing about the regulation, radiation regulation is that we don't have a legal threshold for patient. We have legal threshold for personnel that works in the radiology department for the public, but not for the patient. And there is a reason behind it. For example, if the patient has a big tumor, sarcoma, he's definitely going to die. If not today, then maybe after 5 years. So that's he or she is in pain, and so there is we can argue or we can make our point that if we give a significant radiation, even if it is a significant radiation, we can improve his or her quality of life significantly. And the single exposure, first the CT is few seconds, less than minutes, and the single exposure and that the linkage of that single exposure to the cancer or other type of malignancies, again, not that much clear. So it's not difficult in any radiology or the radiological center to increase up to, maybe 1,000, up to 1,000 liver. That is already window is there. Having said that, there is a principle of ALARA, as low as practically achievable, is the principle. But in this case, yes, we can make it, and it's not difficult even in terms legal terms as well. And definitely, medical. The level we are talking is 1,000 MAs. That is not going to burn and not going to do anything of that sort. So we can make our case, and it shouldn't be that difficult.
And is it? How do you calculate how much energy you want to use? Is it based on the size of the patient, or is it based on?
If size is one, there is nothing like. So if the patient is 100 kg, then we should use this method. There's nothing like that.
Okay.
So it's a lot. It's a department. Department dependent or the subjective thing. So we increase looking at the image. So they have their own experience of practicing. But there is nothing like that in book that if it is 100 kg, then you need 300 MAS, nothing like that. But the general rule is if the patient is, thick, the part of percent part, for example, if the hip is always thick as compared to limb, so the MAS should be high, and there is a range of sort of thing. But there is no hard and fast rule or how, that sort of thing.
When we start getting to radiation therapy, is grey with the dose that's delivered to start getting those tissue reactions that everything that fibrosis, that process.
So with a dual energy scanner, how do they work?
Yeah, I mean,
Radiation doses, I'm thinking, is it?
Yeah.
Do you add those two doses together, and that's the dose?
Very good question. So dual energy, there are different type of dual energy. What it does is that is the biggest problem in dual energy is patient has to expose twice, and then because of that, but the radiation dose should be as low as possible. So they have to make that trade-off, to decrease the radiation dose, but expose twice. So they will manipulate the parameters which cause decrease in the image quality. So that is why dual energy is still not a mainstream imaging modality. And yeah, that's the reason. Otherwise, imaging wise, it's excellent. And that is not case in the photon counting CT. So in photon counting CT, what happens is the exposure is single exposure. So the single exposure and the X-ray beam consists of different energies. So it's a polychromatic. The detector then divide it, bundle it into the energy range. For example, 7 to 30 in one bundle, 30 to 50 in another bundle, 50 to 100 in another bundle, and 100 to 20 in another bundle. So the exposure is single, but we have already 4 different values
To catch.
Yeah, and then it became not dual, maybe it's a penta energy, 5 bundles, penta energy CT. But the problem with photon counting is excellent. The number of photons with a single exposure, and we are dividing these photons into a small bundle or into a small group. Now the number of photon is so low, it becomes noisy because of photon starvation. So if you have noticed in Mars or other type of photon counting, the image is grainy. The image is grainy, and the reason behind it is that photon starvation. And to address that, the detectors should be very, very competent or very effective or efficient. And that is where the whole research is going on. So that is why photon counting is still not a mainstream again.
Because we can't just increase that single dose.
Yeah.
That energy.
Yeah, even increasing, we can increase up to certain level. I mean, we don't want patient to burn, but up to certain level. But then at the same time, even with that, we are dividing it. We are dividing into 8 different bundles or 5 different bundles, and that is why the image quality is grainy, and so it's a photon starvation artifact there.
How are voxels? How do you change the voxel size?
Technically, I don't know, but In every CT scan, you have that option to change it.
So it doesn't involve physically changing.
No, you don't have to do it.
detector.
Yeah, no. For us, we don't need it. Somebody else will do in the factory, but for us, we don't have to do it. There is a green button, you can change it. Just like filtration, when I say 2.5 millimeter of aluminum, and we want to change it to 6 millimeter of aluminum, we don't have to take 6 millimeter thick plate and put it. It's already there. You just have to switch it.
So what's the downside of using smaller voxels all the time then?
Radiation. Radiation is the problem with the smaller voxel size. We have to increase the photon flux. Time and radiation increase because of timing as well. If it's a big voxel, the timing will be less. And if you have noticed, whenever I say tube current, it's MA, and in some slide I use MAS when I talk about radiation dose. So it always comes as a MAS. S means second. So it's not only the flux that is important here. It's how long you giving that flux to the patient. So second, the timing is also important in the radiation protection and radiation dose. So smaller voxel size, time also increase. And it's not always we need of fine borders, which is called a spatial resolution. We don't need it in the clinics. Most of the time we need to diagnose a particular tumor, whether it is osteosarcoma or chondrosarcoma. Once it's diagnosed, that's it. We don't need that borders to be, or even the measurement to be precise. If it's 2.5 centimeter or 2.6 centimeter, it doesn't make that big difference. So yeah.
Thank you very much, Shisha.
Thank you.
Thanks.
Thank you.
How did you go with getting the accountants?
Yeah, I got already. So I think I have to fill with some form for I'm trying to figure out how to do that.
Oh, let me know if you wanted to just send it through and